The reason I'm here is because I think we really want to be, first of all, thankful to Menarini, who is an important international company who has really given us support in the last few years in our independent research, as well as supporting our ranolazine trial. So, and also for this specific meeting, this would not have happened without their help. So we are obviously thankful. This does not mean we are not objective. So, for example, we are very cautious regarding any possible use of ranolazine in cardiomyopathies as yet until we have any data. However, there are a lot of data on ranolazine in other kinds of patients, and very nice data, and that I would like to share with you. First of all, you know that in patients with chronic ischemic heart disease, decision-making is difficult because you have so many options. You have the surgery, angioplasty, and the drugs, and you know that the recent guidelines, in fact, point to the fact that we are probably overusing the invasive strategies as compared to drugs. And even Hamlet seems to suggest that by a sleep to say we end the heartache, and is probably favoring cabbage if you think that sleep may be general anesthesia, God knows. So he's probably over-aggressive on this as well. We'll come back to that later. However, it is undeniable that if you have chronic angina in coronary disease patients, this is quite a problem, not only because of quality of life, but because angina per se is the hallmark of risk. So if you are severely symptomatic with angina, this underlines higher risk of events in the future. And so it is an important red flag for clinicians. One of the reasons for this is that once you get angina, you are up on the ischemic scale. So many other things have happened, including this diastolic dysfunction, systolic dysfunction, ST, so electrical changes, and then angina at the end. We know we have a silent ischemia in many instances. So when you have angina, you have to take it as a very useful clinical marker for risk and treat it. And you know that we have several drugs we can use. All of these are very useful, very effective. We do use them constantly. If you want to use a nice word, we can say these are all pleiotropic drugs, because what they do is they have a number of effects. If you are a clinician, you can call these dirty drugs because they all act in many ways, and it's difficult to identify the specific use you want, the specific action you want, to separate it from the unwanted actions. For example, all these drugs lower your heart rate, which may be good, but maybe not good in some patients, lower your heart pressure, your arterial pressure, may lower your myocardial contractility. So it would be nice to, on top of this, to have something that is sort of cleaner, pure, and can be added on top of standard treatment, which may be effective in our patients with ischemia. And you already know that we have talked about this at length, so I will not spend time on this, but you all know that one of the consequences of ischemia is the inactivation of this low sodium current. And you know that this is exactly where ranolazine acts, by blocking this effect and therefore reducing the duration of the late sodium current, by doing this, reducing intracellular calcium during relaxation. And we have already seen this a number of times. This happens in HCM, but also happens in patients with ischemic heart disease. And the action on diastolic calcium, which is sensibly lowered by ranolazine in patients with ischemic heart disease as well as HCM, this is particularly important. If you think about the pathogenesis of ischemia in the myocardium, it is quite striking how much importance you have to give to the diastolic phase. You would think of ischemia as a sort of systolic phenomenon. In fact, diastole is very important, both because the persistent diastolic tension that you have in ischemic heart disease is a major factor consuming oxygen, increasing oxygen demand, but also because diastolic phase is when the perfusion of the heart mostly occurs, so that you have a double negative action by having a sustained or a reduced relaxation, sustained high calcium, intracellular calcium, and that's, you consume more oxygen and you have less perfusion at the same time. And what ranolazine does, it interrupts this sort of vicious circle by which ischemia begets ischemia by increasing the calcium overload, and therefore reducing the capacity of the myocardium to relax, and therefore consuming more oxygen, impairing perfusion, and so on. By acting at this very early stage, all these changes can be reversed. And so this is very nice to know, but does it work? Well, in fact, it does work. It works very well and very effectively, not only as a single drug, but on top of what is established treatment. So if you give patients with chronic angina ranolazine on top of atenolol and amlodipine, what you can see here, like in the CARIZA study, for example, you can see that all the parameters of ischemia, including symptoms, but also exercise durations, constantly improve. And this is not a temporary fact. This is sustained over time. Patients, very importantly, reduce markedly their need to use nitroglycerin. Think about somebody experiencing regular attacks of angina. This is very unsettling for patients. It makes them feel very fragile. It makes them resort to what we call evitation threat behavior. So that means avoidance behavior. So they would avoid going out, would avoid sports, would avoid leisure activities because they are afraid of reproducing the symptom. So this, in fact, is a major success. What appears to be a little advantage is a major success in terms of quality of life. And this can also be very objectively demonstrated by by nuclear scan, for example. You can see that the defect of perfusion in the ventricle during exercise is very markedly reduced by ranolazine on top of standard anti-anginal treatment. Therefore, at present, ranolazine is indicated as an add-on therapy for patients who are symptomatic with stable angina despite current treatment, despite optimal treatment, or who are intolerant to the classic treatment, in whom standard treatment cannot be used as much as one would like. And this is obviously not uncommon, particularly in a population that is rapidly aging with heart disease. So after demonstrating very nicely how effective ranolazine can be on symptoms and on stable chronic ischemic heart disease, a more ambitious trial was designed, which was the Merlin Team E36, which was a trial that was enrolling patients with unstable angina and non-ST elevation MI, and trying to see whether acute intravenous treatment with ranolazine followed by chronic oral administration was able to reduce the hard cardiovascular endpoints of death or MI, and we know that this is a negative trial with regard to these hard endpoints. However, ranolazine did reduce recurrent ischemia in these patients, which is interesting. And particularly, if you select the large subgroup of over 3,000 patients who had prior angina and then went on to develop unstable angina or non-ST elevation MI, you see that in this large subgroup, in fact, the hard endpoints were in fact reduced, so that you did have less events if you were on ranolazine. What this tells you, and I think this is an important message, is that if you have somebody with ongoing angina, ongoing cardiac ischemia, and you treat him properly, you treat him with the best you can give him in terms of multi-drug treatment, then you increase his chances of surviving an acute event and doing well after the acute event. So you increase his chances of surviving, anything like an MI, for example, which is, I think, not a small message to give. And this was obviously paralleled by increase in quality of life as assessed by the standard questionnaires. And this was, as you can see, a sustained effect of ranolazine over placebo. These are all indicators of quality of life with standardly used questionnaires. You see the advantage seems to sort of increase over time. And also, very importantly, hospitalization due to residual angina was markedly reduced in patients treated with ranolazine. This is also, as you well know, a major determinant of quality of life in a patient. To be able to keep a patient with chronic ischemic heart disease out of the hospital, particularly when old, particularly when frail, particularly when the standard medications cannot be given to a full dose, I think this is a very important. Then let's come to one of the bonuses of ranolazine, which I found particularly interesting also because it has a direct relation to what we do with cardiomyopathies. You know that there are minorities in which angina is very difficult to treat. We have the women with normal coronary angiograms. We know that coronary disease is a lot different in women, and they often have severe symptoms in the absence of epicardial disease. We know that diabetics are very hard to treat. They're very hard. They sometimes don't have the anatomy suitable for invasive revascularization, and they very often have coronary disease, of course. And if you have these minorities, the quality of life is heavily jeopardized, particularly for the cardiologist. So it's nice to know that ranolazine is, in fact, particularly effective in women in whom, again, these are data from the Merlin trial. There is a definitely reduction in recurrent ischemia. And there's a nice case that was presented recently in JACC Cardiology Imaging in which this could actually be demonstrated. So you could actually see that the perfusion deficit, which was seen in this woman with, I think this is definitely hypertrophic ventricle, but anyway, this is not stressed upon by the authors, but definitely had perfusion defects. You can see that on stress. You can see that following treatment, these were definitely reduced. And this is of great interest. How long have we been waiting for a drug that is able to modify microvascular angina, to act on microvascular angina? So this is something we are really looking forward to investigating further in a series of different disease models. And again, ranolazine appeared to be particularly effective in diabetics, and the reduction in episode of angina, the use of nitrates, but also exercise duration. You know that diabetics may have silent angina, so may silent ischemia, so it is important to also demonstrate some objective measure of improvement, which was there with exercise duration. So this is actually a very nice drug for diabetics, not least because of this very unexpected result that was consistently repeated in all the studies with ranolazine, which is the fact that ranolazine definitely improves metabolic balance in diabetics. We still don't know exactly why this is. It may be because of a direct effect on the beta cells of the pancreas. However, it is consistently observed that the glycemic control in diabetics improves on chronic treatment with ranolazine. And this is the last bonus, which is probably one of the most promising as well. Ranolazine definitely has an antiarrhythmic effect. We have talked at length about the effects on, in vitro, on early after depolarization. Well, there is a clinical correlate to this. So, in fact, ranolazine is capable of preventing or reducing the burden of atrial fibrillation in several populations, and there are studies going on at this time specifically addressing this. For example, in this study, treatment with ranolazine prior to cardioversion was associated with a marked reduction in the prevalence of atrial fibrillation post-CABG, post-cardiac surgery. And there are other similar results on the burden of atrial fibrillation in other studies. And similar data, very encouraging data, come from the Merlin trial, also showing that ventricular arrhythmias, as measured on the Holter, non-sustained VT, is significantly decreased in patients with ranolazine. So this is a very nice side effect of the drug. So in conclusion, I think that there is enough evidence out there to in fact, consider inhibition of late sodium current with ranolazine as a very effective treatment, very effective option to offer our patients whom we are treating with standard anti-ischemic treatment. And it is something that is particularly valuable in patients in whom, again, we cannot titrate our standard treatment with beta blockers, calcium antagonists, or nitrates to the level we would want. And also, it may well be that we are using ranolazine, we are protecting our patients from diabetes, atrial fibrillation, microvascular dysfunction. So we are providing not only a direct anti-ischemic effect, but something that may set the stage for advantages in survival, which we think should be investigated in the near future. And just to conclude, coming back to Hamlet, who definitely is quite an aggressive cardiologist, or at least he would be. Later on in Act 3, he confronts his unfaithful mother, saying that she should repent for what she has done. And she answers, "O Hamlet, thou hast cleft my heart in twain." So he says, "Throw away the worst part of it and leave the pure with the other half." So obviously advising her to have left ventriculoplasty, but she hadn't read the Stitch trial, in which this is definitely not the option. It doesn't work. Thank you.
Do you think we should establish a registry for ranolazine treatment while the clinical trial on the benefit? Because, I mean, this is the only way that we can collect data easily.
A registry for cardiomyopathies?
Of course, we are here for cardiomyopathies.
Yes.
And for which, if you want.
Okay, so yeah, I think that the main aim we have is to establish the trials, because I was saying yesterday, we really need to have solid evidence and good methodology to get our evidence and to treat our patients with. So having said that, obviously there will be patients who will not qualify for our trials, and I think, yes, I think if you have a patient who has microvascular angina, because, I mean, after all, HCM patients have that, and you decide to give him the drug, maybe slightly off-label if you consider the indication of atherosclerotic coronary disease, but not totally off-label if you consider microvascular ischemia, then in that case, if you have a patient who you are treating with the drug because of symptoms, then I think we should collect the data. That's probably useful. I would not start giving ranolazine without to all comers unless we have. So I think if we do a registry, then we would need to have specific entry criteria and a nice setup for follow-up as well.
Yeah, some questions from the floor too.
Yes, I would like to talk about the last slide about Stitch trials, because I've seen many times to discuss with these trials, and what I find out that cardiologists mainly knows just the conclusions, but not how the trials was really performed. Because I know that there are many publications in which demonstrate that surgical volume reduction get really benefit to the patient, and if we go to look inside the Stitch trial, we will find out that the volume reduction on that patient was not that substantial as the other trials. So I don't want to make a discussion on that, but just because I feel that sometimes a physician just looks at the conclusion of the trials, not how it goes. So maybe this can arise some other discussion on that.
I wonder whether Bob Bono is no, maybe he's not here, because he was obviously one of the, but yes, this was a very, very difficult trial to perform, and it was almost impossible to perform this specific sub-project of the Stitch trial. So I was only using this for a joke, obviously. I think it was a very important trial, and I agree with you. I think that the real message, the real bottom line is not, not to do left ventricular ventriculoplasty. It is only that it has to be very well tailored and select the right patient, as many things in medicine. I'm not saying it doesn't work ever. I think that the message of the trial is pick your patient very well and then get the good volume reduction. Then, yeah, I agree.
Jacopo, can you talk about the QT data on ranolazine, especially because if we are to use it for microvascular dysfunction in the cardiomyopathies, it would be nice to know that it doesn't do anything bad to the QT, because these patients may be prone to arrhythmias.
Thank you, Lubna. This is a very important point. I didn't touch upon safety for the drug. However, there are very good data in other, non-HCM, but there's very good data showing that the drug is very safe. Side effects are mostly some dizziness and gastrointestinal side effects, which are usually not terrible. There is a warning, which comes with the drug. It says, avoid if patients have long QT because of concerns regarding QT prolongation. However, in patients with cardiomyopathy in particular, with HCM in particular, in whom the QT is long already, we have shown you in vitro that, in fact, there's a good rationale for thinking about QT shortening. So it is something we have to keep in mind. We have to check our QT in the patients before we start the drug. We should not give ranolazine to anyone who is already on a QT prolonging drug. However, and obviously you should take into account electrolytes and give the patient a list of drugs that prolong the QT, because some of them use them over the counter, such as antihistamines or even antibiotics. But having said that, when you do that, I mean, after that, it's really safe. And obviously, we don't have any data on cardiomyopathies. I'm hoping that we will not see anything, and on the other hand, we can even see some sort of positive effect on repolarization, because this is what we have seen in vitro, but obviously we have to see.
Another question, Namdar?
I found it quite interesting that the arrhythmia burden in the atria and in the ventricles are going back, as the drug may have different effects on atrial cells and on ventricular cells. Do you think this is, as you said, possibly a pleiotropic phenomenon, or do you think it's a direct antiarrhythmic effect on the different cell levels?
I think this is simply because it's the same channel it's the same calcium overload that causes it's the same prolongation or repolarization that ultimately causes the predisposition to the arrhythmia, both in the atria and in the ventricle. So it's a common pathway through which the arrhythmias arises in patients with structural heart disease. This is my feeling. I wonder whether Raffaele has performed experiments in the atria, but no, he's saying no. So this is the next thing. I think it's a good suggestion. We should look at the atria and see whether there's any difference there.